my space is filled. Okay, here is your stem, please. Right. So if you've read and understood,
Yes, ma'am.
considering it critical care scenario, please tell me how would you manage this patient?
I would manage the patient according to the Ccrisp protocol using the
Yes.
ABCD approach.
Yes.
First of all, I will look for the airway. I will
Yes.
ask the patient name. If he can tell his name, the airway is patent. But
Yes.
if he cannot tell his name, this means that I will check his mouth. If maybe there is any bleeding or any foreign body in the mouth. And after that, I will check if he can maintain his airways or pharynx. I will need to consider the oropharyngeal airway or endotracheal tube. After
Yes.
that, I will move towards the breathing and ventilation. I would like to give him high flow oxygen around 12 to 15 ml per hour. And after that, I will pass IV line, two whiteboard IV line, and I will take the blood samples for CBC, glucose, full blood count, ABGs, and serum lactate levels. And after that, I will also continue to monitor his urine, and I will resuscitate him with ringer lactate. Along with that, I will arrange 2 to 4 pints of blood after consultation with hepatologist, and
Okay.
I will monitor his urine output, uh, monitor his pulse urine output, and along with that, I would like to do some
Okay.
investigations like to check his INR and prothrombin time. And I would like to do endoscopy for controlling of the bleeding. Like I can do uh, endoscopic banding and sclerotherapy.
Right.
And if if
Thank
if
you.
if the bleeding is okay,
Yes, thank you. Please tell me what are the differential diagnoses you'll consider after reading the stem?
my differentials are esophageal varices, which is due to portal hypertension caused
Very
by
good.
liver cirrhosis,
Yes.
Miller-Weiss tear,
Yes.
Harvey syndrome,
Yes.
and bleeding peptic ulcer.
Can you please tell me what are the pathogenesis involved behind portal hypertension, especially in chronic alcoholic patients?
In chronic alcoholic patient, there is cirrhosis, which actually cause the damage to the liver parenchyma and cause fibrosis and
Yes.
regenerative nodules formation. And this
Yes.
fibrosis actually blocks the portal outflow, and this causes portal hypertension. This is one theory, and another theory is there is atriovenous anastomosis within the liver parenchyma that also cause portal hypertension.
Very good. Please, can you mention the sites where you could find portosystemic anastomosis?
There are a few sites. The most common site is the lower end of the esophagus, in which the portal component is formed by the esophageal branch of left gastric vein, and the systemic component is formed by the azygos vein. The next is upper end of the anal canal, in which the portal component is formed by the superior rectal vein, and the systemic component is formed by the middle and inferior rectal vein. And the third one is the umbilicus. The portal component is formed by the vein in the ligamentum teres, and the systemic component is formed by the superior and inferior epigastric artery.
Good.
And if
Okay.
we move
So,
toward,
in your opinion, in this scenario, which varices is most likely to be bleeding?
I think the lower end of the esophagus.
Okay. Right. What is the significance of knowing that patient is alcoholic and also suffering from hepatitis C?
Uh, Significance. Sorry, ma'am, can you repeat the question?
Yes. What is the significance of knowing that this patient who is alcoholic and is also suffering from hepatitis C? So, what are the complications or the risk factors you should keep in your mind?
Uh, so we should keep in mind that there is there is an increased chance of hepatic encephalopathy. There is the
Okay.
increased chance of there is increased chance of hepatorenal syndrome and acute kidney injuries.
Yes.
And there is a coagulation disorders. We
Very
also
good.
think that there is a coagulation abnormalities and disorder. We also think in mind, and there is an increased chance of continuous bleeding and
And
increased tendency of bleeding as
yes,
well.
and at the end, there is susceptibility that this can result into DIC, disseminated intravascular coagulopathy. So that is the
Okay.
end. Okay, please tell me, right, patients, all right, how would you consider, uh, right, how would you take care of patient's bleeding disorder or the patient situation?
Uh, for the patient bleeding, initially we do endoscopy to control the bleeding.
Yes.
Before going to endoscopy, there is a medical management for that. I would like to do the pharmacological management such as intravenous proton pump inhibitor,
Okay.
intravenous vasopressin octreotide, and after that I will monitor the response. If the bleeding is still there, we can do endoscopy banding, and sclerotherapy. And if
Yes.
bleeding is not controlled with this, then we can go for a Sangstick and Blackie tube or Minnesota tube.
Can you give
And
me a
for
few indications when would you go for platelet transfusion?
uh,
One of
few
them is
indications of
patient
platelet,
is actively bleeding. Yes.
patient
Then,
is actively bleeding. There is ongoing coagulopathy. If there is
okay.
ongoing coagulopathy is there, if there is
Yes.
a continued bleeding is there,
Yes.
and sometime we have to transfuse in the case of massive transfusion protocol as well.
For example,
Like if we have to transfuse
if patient
massive
is
transfusion,
septic or
then
in,
we need to give 1:1 ratio of platelets.
okay, in which situations, like in case patient is in septic shock or if patient is febrile. Okay,
Okay.
in this condition, when patient is alcoholic, hypertensive, and suffering also from hepatitis C, what kind of anemia would patient or can patient can suffer from?
Uh, patient have megaloblastic hemolytic anemia.
Macrocytic anemia, yes, or iron deficiency, nutrition deficiency anemia because of chronic alcoholism. All right, okay. Right, you can tell me, what were you telling me? What are the indications for using Minnesota tube?
Indications of using the Minnesota tube is if the bleeding is continuous and life-threatening bleeding that is not controlled by the pharmacological measures or that is not controlled by the endoscopic hemostasis.
Very good.
And
All
the second indication
yes,
is if these facilities are not available in the particular center,
very good.
then we need to go for the Minnesota tube.
Yes, how should that be used according to the NICE guidelines? Please tell me the procedure.
Okay, madam. We need to put the patient at the 45-degree angle,
Yes,
and after that we anesthetize the posterior pharynx along with
yes,
nostrils with the local anesthesia.
yes,
After that we lubricate the tube and insert the tube up to the mark of 50 centimeter.
yes. And
After that we do aspiration to
okay,
see that
right.
if
Yes, thank you.
from the
Please
stomach
tell
and from
me
the
contraindications when you will not choose to do that.
the contraindication of this Minnesota tube is if there is a recent gastroesophageal surgery,
Yes,
if there is a esophageal stricture is there, or if there is esophageal tear.
very good. Thank you. Excellent.
Thank
Good.